Welcome to the August Talk with a Doc session with Dr. Timothy Leichliter of Allegheny Health Network. As always, we appreciate his time, and I'll hand it over to you, Dr. Leichliter.
Thank you, Casey. Welcome back, everybody, after 2 months of not having it since we had the 4th of July last time. Hopefully everybody is enjoying their summer. I am Dr. Leichliter, for those of you who are new to this, so-called movement disorder specialist here at Allegheny Health Network. My office changed, so I moved to the back part of the hospital now. So if you're my patients, I'm not in the same office I was before. You have to find me. Same rules apply, though. So this is a general question and answer session. So if you have questions, type them in the chat box. I will start with ones that I got on email first. A couple things that I always like to tell people, which is this is a good general question area. So if you do have questions, send them in, because most likely everybody else does too. But this is not a great place to get individualized treatment or care management ideas. Don't say, hey, I'm this, and what do you want me to do with my medicines? That's a good question for your doctor. Everything also you hear is my opinion. And so I have a lot of opinions, which I like to share freely. Even if you don't ask, I will share them. But my opinion is just my opinion. And so if you go to a different neurologist or a different movement disorder specialist, we all have opinions. I like to think that my opinion is based on as much science as I can come up with, but sometimes there just isn't any science there and I make it up, in which case I'll tell you I'm making stuff up and I'll throw up some quotation marks. Without further ado, again, type in your questions if you got them. I'll start on my email on this screen, which is why you'll see me looking, kind of doing these things, and then we'll go from there. So the first one I got was I've been reading about Mucuna. So this is Mucuna purins. This is a over-the-counter dopamine supplement, which I'll talk about in a second. And I wonder what your thoughts are on taking natural Mucuna to replace some of your overall Carbidopa-levodopa intake. So Mucuna it comes from beans. It's either a fava bean or a velvet bean or some sort of legume thing that is naturally high in amounts of dopamine. And they grind it up. It's capsules, it's powder. I've seen a bunch of different varieties of this, and I have a good amount of patients who use it. It does help. Usually I would say my patients supplement what I'm giving them in medications with it. Maybe I have one or two people who are early on who don't really want to get into medicines yet who try it. But realistically, my opinion is that the pills that I give people are so much higher of amount of levodopa or dopamine precursor that they're really going to be significantly more potent than anything you're going to get over the counter or natural. I'm not against using it. And I have a lot of people who kind of supplement in between their doses of Cinemet with Mucuna. Sometimes it helps, sometimes it doesn't. It's one of those trial and error things. I'm not against it if people want to try it. There's not a lot written about it because, again, you're hard-pressed finding good data or good evidence or studies looking at supplements because, again, frankly, nobody's going to pay for a study for a supplement. They're never going to make their money back. And I haven't run into anything harmful or toxic. And so, again, I do have a good amount of patients who use it. Some of them think it helps. Some of them think it supplements what they're already doing with their levodopa. I doubt that you would, if you're somebody who's already taking carbidopa, levodopa, or Cinemet, thinking that, oh, I'm going to take this supplement and I'm going to be able to decrease the amount of medicine that I'm taking. I don't know that I've ever run into that, only because, again, the pills that I give you are pretty potent in terms of the amount of theoretical dopamine they're replacing. And so you would have to take a lot of Mucuna, I think, to make up for it. Again, not that you couldn't try or not that we couldn't work on that, but I doubt that you would be able to significantly decrease the amount of medicine that you're taking by using an over-the-counter supplement. Again, my thoughts are generally that, some people find it helpful. If you want to dabble in it, you're more than welcome to from my standpoint. Make sure you definitely tell whoever's taking care of you what you're doing, but I doubt that it would take the place of your pills. The second one that I got was actually a study. Again, and the question is, what do you think of this study? And the study was basically, I don't think it was a vaccine, but it's a medication that basically decreases the amount of pathological alpha-synuclein, alpha-synuclein being the protein that misfolds in clumps to form Lewy bodies, which is the hallmark pathological finding in Parkinson's disease and Lewy body disease. And basically, through the Michael J. Fox Foundation, Vaccinity is the company was trialing this new alpha-synuclein antibody. Basically, it's supposed to find and decrease the amount of pathological alpha-synuclein, and that's what they were showing in this very early phase 1 study. Now, I say that for a lot of reasons. One is phase one is pretty early. And so at the end of the day, I'm not against looking for it, but I am not an excitable person. And it takes a lot to excite me or get me eager, joyful, happy, excited, all the good nouns or pronouns you can think of. I need to see it in action. I need to see all the trials. I need to see phase 3. I need to see it used in people. I need to see a lot more before I get excited. The other thing about alpha-synuclein, which is a big topic in the world of movement disorders or Parkinson's disease, and I'm sure I'm going to hear about tons of things aimed at alpha-synuclein when I get to the meeting in September, is that a lot of what we're doing in alpha-synuclein in Parkinson's disease is footstepping or following in the footsteps of tau in Alzheimer's disease. In Alzheimer's disease, they have a different protein that misfolds. It's called tau. And they think that's what leads to some of the pathology. But they've been working on tau and Alzheimer's disease for a while, and they've just run into problem after problem. They have not had as much success as we would have hoped for. They're starting to come out with some medicines that maybe are theoretically modestly beneficial. But again, it's taken a long time and a lot of iterations of going through this. And so I don't think in movement disorders and Parkinson's disease, we've necessarily learned our lesson from Alzheimer's disease like I think we should have. So I do think it's going to take us going through a lot of iterations and a lot of progress in this field or this area to get something that maybe works. But again, there is a lot of research going on. I keep my eye out for things like this in terms of progressing forward to in-human trials and randomized controlled trials. And so I think you're only going to hear more and more about medications and targeting of alpha-synuclein. I don't think we're there yet. I think we have a lot to learn and a lot to figure out. But again, studies like this are useful. Mint tea today for anybody who was wondering. I like this question. Does anyone know why someone with Parkinson's has lost so much dopamine? And the short answer is we know tons about Parkinson's disease. We know lots about it, but we really don't know the answer to that question. We don't know the why. We don't know what causes it. We know a lot about what could potentially cause it. We know there's a genetic predisposition. We know there's environmental triggers. We know a lot about the disease, its progression, the gut biome, where we think it starts, how we think the misfolding of alpha-synuclein spreads. There's research on a lot of these things, and we theoretically know a lot of these answers, but we really don't know why you got it. We really can't say for sure you got Parkinson's disease because of this, or yours came from this. And that's really the difficulty in trying to fix it, is that we just can't figure out how to pinpoint where it starts, why people get it, and so on and so forth. And so, no, the short answer is we don't know why, people with Parkinson's disease have lost so much dopamine. Something destroys the dopamine producing part of the brain. So this is generally in the substantia nigra, which is just a fancy word for saying brainstem or deeper structure of your brain. And for some reason, those cells take a hit. We know that mitochondria play a role. We know the energy producing parts of the cells play a role. We know a lot about a lot of things, but we don't really know why it happens. I think that's part of this big picture that we really need to figure out before I think we can get to the point of cure or fix. But again, it's one of those unknowns that we just haven't quite wrapped our head around yet. Can you please explain how carbidopa-levodopa works? Does it give you dopamine temporarily? And have they looked at any treatment that creates dopamine in your brain or body that lasts forever? I like this question too. So yes, I can explain how carbidopa-levodopa works. So carbidopa-levodopa is a combination pill, hence there's two names. That's why it's so hard to say. The levodopa part, the second part, so the bigger number part, that's usually 100, can be 250, can be 200. Levodopa is dihydroxyphenylalanine. So DOPA stands for that. And it basically is the precursor before dopamine. We learned a long time ago that you can't just feed somebody dopamine. It does not get from the stomach or the GI system up to the brain. We tried that first. Didn't work. But we found that if you use levodopa, which is the step before dopamine in the conversion or the pathway, it does cross the blood-brain barrier. It does get from the gastrointestinal system to the brain, where it then gets converted into dopamine and replaces dopamine that we think is lacking or missing in Parkinson's disease. The carbidopa part prevents that from happening in the stomach and the GI system. So we want it to get converted from L-dopa or levodopa to dopamine, but we want that conversion to happen in the brain, not in your stomach, not in your GI system, not in your peripheral blood system. We want it to happen in the brain. And so that's what the carbidopa part is for, is to try to prevent that conversion from levodopa to dopamine from happening anywhere else except in your brain. We have not figured out how to create that permanently. We have not come out with good long-term lasting medicines or long-lasting versions of levodopa or dopamine. We have not figured out how to make your brain reproduce dopamine. Probably the closest that we've got to something like that is stem cells, which again, there are things being written about and they're still working on, but we're not there yet. But realistically, recreating that dopamine in your brain for a permanent or forever standpoint would really require reproducing, regrowing, resprouting nerves or nerve terminals that can produce dopamine. And we just haven't figured out how to do that yet. And so that's how carbidopa-levodopa works. That's why we think it's the best medicine for Parkinson's disease, where we think if Parkinson's disease really is a dopamine deficiency, and this is the best or closest way we can get to replacing dopamine, that's why we think it works the best. But we just haven't figured out how to do that naturally or more permanently. What are my thoughts on the environmental contributors to Parkinson's, such as pesticides, paraquat chemicals, trichloroethylene, or perchloroethylene? I think there's something to it, but I'm not sure. Again, interestingly enough, we've known for a while that environmental triggers can lead to Parkinsonism and Parkinson's disease. The three that have been kind of most written about are Agent Orange. And so I do have a lot of Vietnam veterans, people who were exposed to Agent Orange who get a stipend through the government and through the VA because of the correlation seen there. Industrial strength pesticides, so farmers spraying their fields and crops have been known to develop Parkinson's at a much higher rate. And manganese toxicity, which was initially found in South American manganese miners who all developed Parkinson's disease. And now we think about manganese in more well water. We think about the water contamination down at Camp Lejeune for the Marines when they were training during that time period that I don't know what it is. And so are some environmental or chemical triggers that we're relatively confident in. And then there's the newer ones that are talked about, the trichloroethylene, the paraquat, the Roundup, the perchloroethylene. I mean, all of these things are being correlated and associated with the development of Parkinson's. But it's tough because it's really hard to prove. It's very easy to say, hey, there's a correlation here. It just seems like people who are exposed to these things develop Parkinson's, but it's much, much more complicated and more difficult to prove a cause. And so again, there people are working on this. There's books written about this. Dr. Dorsey was famous for this, his book and his philosophy on this. And again, there are people looking at this, and I think there's probably something to it. But the problem with it is I don't know what to do with this information just yet. This is the kind of information that we say, okay, if we think this is true, our next step is lobbying the government to get rid of these things. But well, you can imagine how well and how easy that goes. But from a day-to-day practice standpoint, it actually doesn't change anything that I do, because by the time you're coming to me, you've already been exposed to these things, or it's already caused the problems. And there's nothing, as far as I know, that would treat people who exposed to this or with Parkinson's symptoms caused by environmental chemicals that I would do any differently than anybody else who comes to my office. And so while it's interesting information, and yes, I do think that people much, much smarter than me need to keep working on this. And if there are definitely causes, if there's ways that we can take these chemicals out of the environment or stop companies from using them in degreasers or plastics or manufacturing or wherever else they're used, great. But lowly me is just going to sit here and keep taking care of patients regardless of the underlying cause. And I don't think that's going to be made any different based on these kind of chemical things. So again, I think it's an interesting field of study. I think there's a lot of work being done in it. I think eventually it's going to have to get to the government level to really figure out how to take these things out of use or, decrease the likelihood of exposure to these things. But until we have more precision type medicines or treatments specifically for these kind of things, it doesn't actually change what I do. All right, couple more, and then I'll get to whatever's going on over here in the chat box. So keep typing your questions over there. Thought this was an interesting one too. So can you please discuss the different forms of Parkinson's disease? So the Parkinson's Foundation had a webinar that defined two different types of Parkinson's. One was tremor predominant, one was gait instability predominant. And the question is the protocol for treating each the same or somewhat different? So interestingly enough, is we've talked about different subtypes of Parkinson's disease for a really long time. In fact, even when I was a fellow back under Dr. Baser, we would talk about this, mainly differentiating those two groups. So tremor predominant versus postural instability, akinetic rigid, balance problem predominant. And it was always thought that the tremor predominant people did better. It was always thought that the tremor predominant people did the best. They responded best to the medicines. They progressed the slowest. But there's been a couple of reports that came out that really that doesn't necessarily hold as much water. There are plenty of people that come in with more of the akinetic or the difficulty with mobility, rigidity, and balance problems that actually do pretty well for quite a long time. And likewise, there's a lot of patients that come in tremor predominant that decline at a much steeper rate. So the most recent things that I had seen was that it isn't necessarily all that useful to differentiate or distinguish between the different types or presenting features of Parkinson's in terms of predicting the outcome. We're not going to be able to look at you and say, "Ooh, you're tremor predominant. That means in 5 years you're going to look like this," or "You're a little bit more rigid. You're going to not look like this." We are not that good at predicting, and so distinguishing or differentiating between the subtypes doesn't necessarily help me predict how you're going to do. It also doesn't necessarily change how I treat you. Maybe in terms of walking in balance, I'll use more like amantadine, or sometimes I'll use Exelon, which is an Alzheimer's disease drug, because I know that maybe Carbidopa-levodopa and pramipexole aren't as good for walking in balance as they are for tremors and stiffness. But realistically, at the end of the day, I'm going to treat you pretty much the same. Everybody gets put on Cinemet first because it's just the gold standard drug and really the best choice in terms of quality of life first. And then I'm going to increase it the same I would in most people. I'm going to layer in different medicines the same I would in most people. Now everything is individualized, and so how I decide the medicines that I'm going to put on or the progression of medicines really is individualized. It really determines or it's decided by what I'm trying to accomplish, but that's going to be true no matter what subtype you have. I don't think we've been good enough at this point to really distinguish the two in terms of specific treatment strategies or one works better than another. I'm going to harp on you about exercise regardless of what you look like. I'm going to use tons of physical therapy, speech therapy, occupational therapy, all the same things that I would use for my tremor predominant people. I'm going to use for my akinetic rigid or postural instability patients. And so I don't think it necessarily changes how I treat you or gives me a lot of insight into what to expect. So I really don't spend a lot of time trying to distinguish or differentiate the different types of forms. I both liked and didn't like this question too. So this is the last one I have in email, because I like it because it's a great question, but I don't like it because it doesn't make me look very good. And so the question is do you look at the whole picture as far as gut health, brain health, and other health issues like osteoporosis during your office visit? And the short answer is no. I am a lowly neurologist and I am only good at one thing. I am not a very good primary care doctor. I'm not very good at looking at the whole picture. And it's tough because Parkinson's disease causes all of these things. Literally every system known to man is impacted in Parkinson's disease. Does that mean I'm the best at every system known to man? Heck no. And so should I care more about things like osteoporosis? Well, I mean, this is why they're doing the Topaz trial over at UPMC, looking at how people with Parkinson's disease with bone densities do. Yeah, I probably should, but I'm not very good at bone density. I honestly don't know how to check it or what to do with it. Should I pay attention to gut health? Well, I do to some extent because it's symptomatically involved in Parkinson's disease. But am I the expert at motility and different things for, gut problems? Not really. Should I be more concerned about blood pressure fluctuations and heart problems? Yeah, I probably should, because all of those are impacted in Parkinson's disease, but I just can't, because I can't learn about everything is the short answer. I'm only good at kind of what I do. I know what I'm good at and I know what I'm not very good at. Should I be able to take care of everything as a whole? I mean, maybe, but I just don't think I can wrap my head around that much information. My simple brain can't grasp all of the different things that could possibly impact it in Parkinson's disease. And so the short answer to the question is no, I cannot fathom to take care of the whole picture. I can get you to people who can. And so this is where you'll see me do it in the office. So we'll talk about all of these things, or I always ask what else is going on. And I want you to bring up all the things, even if you don't think it's something that I'm the expert in or can figure out. Because if I can't figure it out or don't know what to do about it, my plan is usually let's get you to somebody who can. This is also where a good primary care team is really important. They are much better at having the big picture, the whole picture in mind. And so again, I thought it was an interesting question. It doesn't necessarily make me look the best, but it is a good question because it is important for patients with Parkinson's disease because everything really is impacted. And what that means is I am not going to be the best person at everything that you have. Hopefully I can figure out who is so I can tell you where to go. And I definitely know how to manage the things I know how to manage, but this is where it really does become a team effort. And hopefully, if you've listened to any of the talks that I've given, or even if you haven't, if you've listened to a lot of things, you know how important it is to have a team. Um, this is not a one-man show. Not just in your healthcare, but in home life as well. And I see a bunch of couples and several people on the videos. This is not a one-man team. You need a team of caregivers. You need a team of doctors. You need a team of therapists. Taking care of somebody with Parkinson's disease is a really big group effort, and you really do need multiple different people, multiple different doctors, multiple different subspecialists to really try to get the most benefit of taking care of all of the problems that you have. And yes, I can handle a lot of it. Yes, I'm probably a big part of it, at least in my patients in terms of their disease, but I'm by no means going to have the entire picture in mind when we're talking in the office, and we're going to need other people on board to help. So again, I don't know if that's good for me, but such is life. All right, now I'll go to the chat box here. How do I know if I need a long-acting or sustained release Cinemat, especially at bedtime? How do you feel when you wake up in the morning? So a lot of things, and that's not the only way to solve that problem either, by the way. And this is where this is the hard part or the individualized part of taking care of somebody with Parkinson's disease. If you can come up with a problem in Parkinson's disease, I can probably come up with a solution or a plan for it. But I can probably come up with about 4 different ways that I could try to solve your problem. And then you have to pick and choose what's the best way, right? And so I use the Cinemat CR when people are waking up in the middle of the night and to go to the bathroom and they can't move, or they're waking up in the morning and they're very stiff and very slow. Because again, I have a lot of people who take pills every 4 hours, 5 hours, 6 hours at night, and then wonder why they go to bed at 10 and they wake up at 3 o'clock in the morning and they every night and they can't move. I'm like, well, I don't want to be the bearer of bad news, but if your pills wear off in 4 hours while you're awake, they're probably wearing off in 4 or 5 hours when you're sleeping, and that's what's waking you up. So that would be a great reason that I would add a controlled release at bedtime. But another solution would be Ritari. Ritari is a immediate release and controlled release in one capsule, a new pro patch. Maybe I just have you, not that I usually condone this, this is never my favorite plan, but maybe when you wake up to go to the bathroom in the middle of the night, you take an extra pill. There's a lot of different ways you can solve every problem, and it's very individualized where we coming up with what's the best way for you. And so talking with your doctor about what the problems, your job is not to come up with the solution, in case you were wondering. Um, it's not a problem if you do, at least when you come to me. If you tell me, hey, this is what I think I need, I'm usually, as long as it's reasonable, more than willing to work with you and say, okay, let's try that. But it's not actually your job to figure out how do I adjust my medicines to do better. It's your job to tell us what the problem is. And then based on what the problem is, we say, okay, this is the way I think is the best to try to solve that problem. So again, if somebody comes into me and they say, hey, I'm taking my Cinemet during the day and it's working, but man, when I wake up in the morning, I can't move. I have a hard time getting out of bed. I'm very stiff until I take that pill, and it takes about 45 minutes to kick in. Then I can start moving again. I'd say, okay, let's try taking a controlled release Cinemet at bed. See if that wraps around to last a little bit longer. Cinemat CR doesn't necessarily last 12 hours or 24 hours by any means, but maybe it lasts a little bit longer than the immediate release does. And the reason why I don't like Cinemet CR during the day as much because it doesn't work as well. So people don't feel it kick in or work as much as the immediate release. And so that's why I don't use it as much during the day for my patients, but it's not uncommon for me to add one at night, particularly if you have those types of complaints. So again, the short answer to your question is you don't have to be the one to solve these problems. You just have to be the one to relay the information for what is bothering you, what is the problem, and then let people like me come up with what are the potential solutions or options, and then we pick the best one. Is there a better time of day for protein intake, and does it affect on or off episodes? It can. And so there's a lot written about this in Parkinson's disease. I don't know that there's necessarily a better time of day for protein. Some people eat their biggest meal or heavy protein for breakfast and then don't eat as much during the day. Other people were like me, don't be like me, where you skip breakfast, you drink coffee for breakfast, you have maybe a protein bar if you're lucky for lunch, and then you eat a whole pizza for dinner. I don't recommend my diet to anybody, but it gets me through the day. But I have a lot of patients who eat their biggest meal at dinner, lunch, breakfast. It doesn't matter to me the timing of things, but you're right when it comes down to protein can interfere with the absorption of your pills and could lead to potential on-off. So it turns out that protein or large amino acids compete for the absorption of the levodopa. That's why. And so I always think about a train. A train has so many cars on it. If you're, and everybody's a little bit different, and it's really genetics that just tell you how many cars you're going to have on your train. So if you're somebody that's genetically, predisposed to having a huge train, and you got cars galore that can carry protein and levodopa and everything across the blood-brain barrier, you can take your pills and eat a steak, and it's still going to work. But if you're somebody that doesn't, if you're somebody that only has a couple of cars on your train or this carrier protein, well, then they're going to be competing for that levodopa. And so, whereas you might want that train to carry as much levodopa across the blood-brain barrier as you can get because you need every last ounce of that levodopa to move, and then you eat some a protein or large amino acids, and those cars get filled up with the protein and not levodopa, your pills aren't going to work. And so you really don't know until you try it, but there are a lot of people who do notice that their medicines are less effective if they take it with meals or particularly high protein meals. And then you have to figure out, okay, well, what do I do, right? Especially because if you come to me or if you're having a lot of fluctuations, maybe I have you taking pills 4 times a day, 5 times a day, 6 times a day. I have some people that take Cinemet every hour. It's not ideal. It's not what I'm aiming for, but it's not outside of the realm of possibility. And so invariably they come back and say, what am I supposed to eat? And it's a big issue. And so again, we hope not to end up in that situation, but you do have to be aware that there could be a change in the effectiveness of your levodopa or how well your dopamine works if you take it with protein or in and around the time of eating meals or particularly high protein meals. So generally what I tell people is now the other hard part is levodopa's biggest side effect is upset stomach or nausea. And of course, eating with it tends to help with the nausea. And so it does become this battle between how do we get enough medicine into you? How do we get it to work better or maximize its effectiveness? And what I usually tell people is, especially when they first start taking their pills, if you take it with food, fine. If it doesn't make you sick, try taking it on an empty stomach, preferably, a half hour before you eat, an hour after you eat to try to avoid that. But again, you won't know until you try it whether or not protein actually impacts your absorption of your medicines or if it's actually going to make you turn on or off. Again, that's kind of the long and short about it. Why would I feel worse in an hour after taking your Parkinson's disease medicines? Well, I can think of a few reasons why that would be the case. One is your pills don't work, maybe. 2 is you're taking your pills or your pills take a long time to kick in, and then you take a pill as your last pill is wearing off, and then it wears off before your next pill kicks in. Or I had another idea, but I can't remember it off. I lost it. It's gone. The long answer is I'm not sure. Maybe it's actually a side effect of your medicine. That was the third idea I had. Is that maybe your downtime or whatever you're feeling is actually a side effect of your pill. That's a hard one to try to figure out because, again, unfortunately, the medicines are a double-edged sword, right? Not only do they theoretically help people feel better with Parkinson's disease, they come with a hefty price tag of side effects. Maybe your blood pressure is dropping an hour after you take your pill. Maybe it's that nausea that's kicking in. Maybe it's a dyskinesia and it just feels like an off episode. I mean, there's a lot of things that the pills can do that we don't want them to do too. Believe me, we don't have a perfect solution. And so there's a lot of reasons why, and believe me, you're not alone in this. I do get a lot of patients that say, man, after I take my pills, I feel like crap. Um, After I take my pills, I have to go take a nap. Maybe it's making you overly fatigued. Again, I don't really know. And this is where it gets a little bit tricky trying to figure out what to do because I can't necessarily say, well, stop taking your medicines because then you won't feel very good either. And so that's a tricky situation where you're trying to figure out, do you need less more frequently? Do we need a different version of the medicine? Do I need to try something different? Um, how much worse do you feel, and can you suck it up and wait it out? I mean, these are all the choices that we would have, and that would be a little bit of a challenging problem, but not an uncommon problem. And again, there's a lot of reasons why that could be the case. Why would I have an off episode every day about the same time, regardless of what I had taken when I had taken my pills? I mean, that's another thing that I hear commonly that I don't necessarily have a great explanation for. I can tell you that a lot of people tend to have a downtime or an off time, kind of afternoon to early evening time. That theoretically is kind of a downtime for everybody. It's when your brain supposedly naturally makes the least amount of dopamine. And so a lot of my patients kind of 2 o'clock, 3 o'clock, 4 o'clock say, I need a nap. I just don't feel as well. We need more medicine. But otherwise, I'm not sure because off times are variable for most people. It depends on so many different things, including not just your medicines, but also your mood, your sleep, your food, your exercise level. There's so many different things that go into pill effectiveness, wearing off times, down times, good times. And so it's always hard to predict. If there's any way you could pattern anything that seems to be consistent, I would look into that. But that's a tough one in terms of why you would have one at the same time every day. Again, the only thing I can think of is that people do naturally have a downtime and how much dopamine they produce, and maybe that's your time. Lot to that one. Questions about hypotension. Do people taking levodopa every 3 hours or less eventually develop hypotension? That's low blood pressure. Have you noticed any pattern with how much levodopa you take and the development of hypotension? Are dyskinesias and hypotension the most common and most dangerous adverse reactions of carbidopa-levodopa? I'm not sure really to any of those questions. The hard part about the hypotension part is that hypotension is also a symptom of the disease itself. And so as your disease progresses, in particular, the autonomic system becomes more impacted. So a lot of patients end up with orthostatic hypotension, which is your blood pressure goes down when you stand up, but you can just have low blood pressures anytime sleep gets impacted, bowel and bladder, all things that should be automatic, which are controlled by the autonomic nervous system, are impacted. So that the disease in and of itself can cause hypotension. The medicines can also cause it. And so that's where it gets a little bit tricky. I don't think there's a specific amount or interval or dose that seems to lead to it more than another. Some people are just sensitive to it, and very low doses cause their blood pressure to go down. Some people, after they're on it for years, it's a combination of disease and medicine in terms of low blood pressure. So I don't know that the 3 hour mark is necessarily magical. I do think the more medicine you're on, the more side effects you get, including low blood pressures. And I do get a lot of people that start off with high blood pressure, meaning their primary care doctor has them on low blood pressure medicines to lower their blood pressure. And as their disease progresses, or as I add in other medicines, a lot of times they're able to come down or off of those other medicines. But it's definitely something we have to be aware of and keep an eye on because low blood pressures aren't very good either. But I don't know that there's any necessarily dosing or timing interval that I'm like, oh, once we get to this point, you're going to have problems with blood pressure. I really think it's more variable than that. And while dyskinesias and hypotension are common, are they the most dangerous? Mm, Maybe. I don't know. I liken all of the side effects as kind of on the same playing field. So orthostatic hypotension or low blood pressures, dyskinesias or flailing movements, hallucinations, seeing things or hearing things that aren't there, motor fluctuations, kind of on-off episodes, which is actually a side effect of how we deliver the medicines. I mean, they're all not great. I don't want to use the word bad, but they're all not great. And so I don't know if one is necessarily worse than another. Believe me, if you have some of the scary hallucinations that I've caused in some of my patients that I've heard about, they're significantly worse than the dyskinesis or hypotensions. Whereas if you're passing out, clearly that's your biggest problem. And so I don't know that one by nature is necessarily worse than another, but they're all problematic and they all need to be addressed and they all need to be brought up and talked about. Since levodopa helps improve movement and I'm taking 3 carbidopa-levodopa pills per day, I should take them when I need to move. And taking the third pill late in the evening before bed makes no sense. I don't know that it makes no sense, but there's arguments either way. So I have people who take pills 3 times per day, tons of them. Some people take them breakfast, lunch, and dinner. Some people take them morning, afternoon, nighttime. Some people take them kind of during their working hours because that's when they need to feel better. There's no right answer to that question. It really is, what are you trying to accomplish? What are you trying to do? I have some people that don't do well if they don't take pills at night. They get very stiff and they can't sleep at night. When they get up to go to the bathroom in the middle of the night, they can't move. And when they wake up in the middle or in the morning, they feel terrible. Well, it makes a lot of sense for that person to take a carbidopa-levodopa at bedtime. Whereas I get people who don't feel like that and find that if they take their pills during their waking hours, they move better, they feel better, they're able to do all the things they want to do, and that's fine too. I don't think one answer is right compared to another. It really is user dependent, and I would say do whatever makes the most sense or works the best for you and stick with that. That's also why it's not uncommon for me to start with 3 times per day, but then quickly go up to 4 a day, because I find that taking it breakfast, lunch, dinner, and bedtime actually help people do a little bit better. Not that I'm in a rush to give people more medicine, but that's what you'll see me do pretty commonly in my office. Because again, the biggest downside to levodopa is it just doesn't last very long. If you get 6 hours out of a dose, you're doing well. Usually it's closer to 4, and that's why it's so frequently dosed. And so how you split it up is a little bit subjective. It really works for, or really is best done whatever makes the most sense for you. I agree. So I've heard Parkinson's to be a syndrome and not a disease, making it harder to fix. What do you think? I agree with that 100%. We've been saying that for a long time now. And the difference is that a syndrome is a collection of symptoms, which is what Parkinson's disease is. A disease actually has a definitive underlying pathological marker, which Parkinson's also has. But I really view it as a constellation of symptoms more than one specific thing. And this is actually super important when it comes to the how do you fix it part. Because I view it as a syndrome, meaning you get the diagnosis with Parkinson's disease, not because I cut open your brain and I look at your dopamine producing cells and I say they're not there, because that doesn't end well for you. So I usually don't go to autopsy for a diagnosis. But it's a syndrome because you get diagnosed based on your symptoms. So anybody who comes to my office with the appropriate symptoms in the appropriate setting, with the appropriate progression and the appropriate response gets labeled as Parkinson's disease. But what I'm basing that diagnosis on is actually the end result of a bunch of different things. Hence, we know there's about, I don't even know how many genes we're up to for Parkinson's disease. Hence, we know all the things that were mentioned in the other question about genetic or environmental triggers. There's a lot of different things that add up to all look the same, which we call Parkinson's disease. And that's why I view it as a syndrome, because it's a bunch of different things that add up to the constellation of symptoms. That makes it really hard to fix. Let's say I come up with a cure for a very specific genetic and environmental cause of part of this syndrome, this constellation of symptoms, and then I want to try it in Parkinson's disease. Well, guess what? I'm not going to trial it in 1,000 people who have this specific problem because, again, that's precision medicine and we're not there yet. It's going to get trialed in everybody who shows up as Parkinson's disease, and it's not going to work because it doesn't fix everybody with Parkinson's disease. It only fixes one subtype that leads to that constellation of symptoms. And this is exactly why I think it has been so difficult for us to come up with a disease modifying or a cure. I really do think we have to get to the first part. We have to be able to look at the genetics or look at the environmental triggers or look at the underlying cause of the constellation of symptoms and be able to distinguish those, which we cannot do just yet. before I think we're going to be able to get to the point where we can fix it. And then I think we're going to have more precision medicine, which is we do a blood panel or a test or whatever profile, and we say, this is your specific problem that has led to your symptoms, and I have the specific treatment for your specific problem right here. I mean, that's the goal. I mean, that's the gold standard. That's the holy grail. That's precision medicine in a nutshell. And unfortunately, we're not there yet, but that's exactly what I think. Correct. So why do I not do any tests to determine what toxins appear in patients with Parkinson's disease, bloodstream or urine? It could give an indication clue to the patient how to change their environment, reduce further exposure, and some detox methods do exist. Maybe. It would also provide more data to the effort to determine why so many people in and around Parkinson's or Pittsburgh have Parkinson's disease. Are there any good toxicologists in Pittsburgh? Sort of. So that's exactly why I am not a toxicologist. Much coming back to what I am good at. We do have a toxicologist here. His name is Dr. something, and I can't remember offhand. He's super nice. I've met him many times, and I feel bad for not remembering his name. It'll come to me a little bit down the road. But toxicologists are actually really hard to find. There were many years where we actually didn't have a toxicologist here at Allegheny Health Network. But at the end of the day, part of the reason is a lot of the things, unless you're continually being exposed to it, it's actually really hard to test for. Manganese, for instance. If you're not actively being exposed to manganese, your manganese level is going to be 0. You rapidly clear it. However, it still can cause the problems. I don't think we have a test for Agent Orange. I'm not sure there's a blood test for trichloroethylene. I mean, I don't think these are easily testable things. And if they are, I'm pretty sure we don't have the norms or what's positive, what's negative. And again, contrary to what you tell me, I'm not sure what detox methods actually exist out there, or chelation therapies or ways to get these toxins out of you actually get out there that have any actual kind of double-blinded randomized controlled trials to support their use. And so all of that is why I don't do it, mainly because I don't know enough about how to do it, how accurate the tests are, or what to do about the results. I'm not keen on sending people for tests that I don't know what to do with, and so that's why I don't do it. Could it be useful? I mean, especially for the last part of what you said, there does seem to be a preponderance of people with Parkinson's. It has a lot of P's. People with Parkinson's disease in Pittsburgh. That was a very big alliteration. And I'm not sure why. Now, we do have an older population, and age is the one across the board risk factor that we're pretty sure about. But I also can't tell you how many times I see a patient and they're like, yeah, I worked in the steel mill and I got about 12 friends who worked with me who all have Parkinson's disease. Or I grew up in this town and 7 people on my street have I hear these things day in and day out. I do think there is something to it. I just don't know how to test for it, use it, have that be of any benefit for me. If and when I ever do figure out our toxicologist's name, I mean, maybe it would be a reasonable idea to reach out to him to see what his thoughts are. I've never come across a toxicologist who specialized in things like this or Parkinson's disease. There may be some working out there, probably at the bigger academic centers like Harvard or Mayo Clinic or things like that. But again, it's an interesting thought. It's just that I'm not very good at that. I don't know how to test for a lot of these things, and I'm not sure how accurate the tests really are. And I don't know what I would do about it if I found those in the end result. And again, when is the extended release carbidopa-levodopa used? So there's 2 different versions of extended release carbidopa-levodopa. Two. One is Cinemat CR. This has been around for a long time. It's what I predominantly use at bedtime if people are waking up in the middle of the night or they don't feel very good in the morning. And I don't like I use it sometimes during the day, but I don't use it as much during the day because people really don't feel at work as well. Ritari is the other kind of long-lasting version of carbidopa-levodopa. It's immediate release and controlled release in 1 capsule. And so the Amneal, I think it was Amneal, the people or the company who made it were like, hey, if the immediate release kicks in and people feel it work better, but it doesn't last very long, and Cinemat CR lasts a little bit longer, but people don't feel it work very well, well, what if we put both of those in 1 capsule? And that's exactly what they did. And to some extent, it does that. I do use Ritari fairly frequently. That I do use during the day because people do feel it work, but I also use it at night. And again, it's much like everything else. In some people, it's great. They love it. They do really well with it. And some people, they're like, nope, that's no better. In fact, maybe it's a little bit worse. I'm switching back to regular Cinemat. Again, how we change medicines or what we what we do from a medication standpoint is very, very individualized. There is, and this is why it's so hard for medical students and residents, and even, nurse practitioners and PAs that I train. You really have to spend a lot of time taking care of patients, seeing a lot of patients. This is what I did in my fellowship. I spent an entire year basically being Dr. Bazer's tail, seeing just thousands of patients because she had thousands of patients. And that's the way you kind of get the feel for when do we do what? When is a Cinemet CR the right choice? When is it better to switch to Rotari? When should we add a Nupro patch? When should I layer in Mirapex? When do I use Azilect or Selegiline? When do I go to Norians? All of these options that we have are really very, very individualized and subjective. And it's because, again, I can come up with a lot of different solutions for every problem that you have, and picking and choosing the right way to do it is individualized. Part of it also depends on my mood. I may do one thing one day and a different thing the next day. You never know. That's what my residents would tell you, at least. But I like to think that it's very individualized. There's a reason why I pick what I pick for each person that I pick it for. And so the same thing is true for the extended release Carbidopa-levodopa. There are certain people that I think it makes a lot of sense for. There's certain people that I think other ways to try to solve the problem are better. And sometimes I can explain it, sometimes I can't. Sometimes I just have a feeling. But it's usually kind of a decision that I make based on a lot of different variables, and you just have to figure it out. Yes. Last question on here. I got time, so if you have other questions, feel free to throw them on there. But Casey's question: are there new doctors coming? Are there new movement disorder specialists coming? Because I don't want to just exclude say doctors. And the answer is yes. So not only do I have my team here, including Dr. Flaherty down at Jefferson, who we trained at Allegheny Health Network. I don't know what UPMC has. I'm not sure if they have more doctors or more people coming, but at Allegheny Health Network, at least help is on the horizon. So I have myself and Casey, who's my nurse practitioner here, along with the rest of my team of nurses, nurse navigators, things like that. I have Dr. Flaherty, who did do a movement disorder fellowship with us down at Jefferson, although she still sees a lot of general neurology down there. She has her own APP down there that I always blank on her name too. Anyway, I recently trained a physician's assistant named Stacy to go out to the Monroeville area because, again, Dr. Baser had a ton of patients out there. There are a lot of people who come from the east who do not like to come to my office here in the North Shore or on the north side. And so I have a PA named Stacy out in Monroeville. She's at Forbes, but I think she's moving to the Premier building in the near future. I'm not sure when, who I personally trained in this and is very good. I have another PA that I'm currently training named Christina, who will probably be up and running in another month or so, who will be either here or I'm probably going to find a place in the South Hills to station because that's another area that we don't cover very well from a movement disorder standpoint. And then I have two more neurologists starting in a month. So one is they're both fellowship trained in movement disorders. One will be full-time movement disorders like myself. One will be part-time movement disorders and setting up a potential integrative medicine clinic. And so the short answer is more to come. Yay, South Hills. More to come from a help standpoint, because I know it's tough. Believe me, I know how long it takes to get into my office or any movement disorder specialist office in Pittsburgh. Even UPMC, I'm pretty sure, has long wait times. Those guys are very good, but they're just as stretched as we are, because again, there's so many people in the Pittsburgh area. Casey keeps telling me a different number every time, and it seemingly keeps going up. What are we quoting now? 10,000?
I heard 18,000 in Western PA.
Like I said, the number keeps going up. Every time we talk, you give me a higher number, and guess what? There's like 6 of us, and so do the math. It's not easy to find us. It does take a long time to get in, but we are working on that. I'm training more people. We're hiring more people. So hopefully that will come to fruition, and then my wait time won't be so long. I'm very happy and eager for these guys to get here. I interviewed them myself. And so I'm happy, at least from an Allegheny Health Network, that there's a light at the end of the tunnel, that we're about to have a lot more help. A couple more questions came in that I'll answer. So is rubbing of the fingers together on a regular basis a sign of Parkinson's disease? Kind of. I mean, so I do have people who come in like that. The tremor in Parkinson's disease was initially described as pill rolling, which is kind of one of these things. But I also see people kind of sit and do one of these weird things with their fingers outside of their consciousness or their thought in my Parkinson's patients. And so even outside of what the typical tremor is, they kind of have these hand movements. I think there's something to it. I've seen it enough in my Parkinson's disease patients, and I can't think I've seen it in a lot of the other things. And so it could very well be a sign or a symptom of Parkinson's disease. It's definitely not written about as much. Usually it's kind of lumped together with the tremor, but I do think there is something to it because I have seen it enough. In an ideal world, how often do I think somebody should be seen? That's a great, it's variable. Um, Anywhere from realistically, if I'm seeing a patient and they're not doing as well as I would like them to be doing, and I'm changing their medicines or I'm increasing things, 3 months would be ideal. I would prefer to see my patients every 3 to 4 months. I can't do that. I mean, it just does not fit into my schedule. It's just not a thing. And so it's usually closer to every 6 months. Although if people are doing well, every 9 months or every 12 months is fine if we're not doing anything. The downside to, or I don't want to say the downside, the alternative to seeing somebody so frequently is messaging. And so every health system, I feel like nowadays, has some sort of messaging system. I know UPMC has their own link. We have my chart. And so a lot of what we end up doing is via messaging. And I could make the argument that I don't really need to see you that frequently in person and poke you like I do, as long as you can update me on how you're doing. And so, again, while it's not my favorite way to do it, just like video visits aren't my favorite way to do things. I mean, not that I'm that old, but I have an old mentality of I don't like to change and do things differently. Um, it can be done, and this is the way of the world. So, since I don't have the availability or the office space to see patients as frequently as I was like, oftentimes we do it via messaging, and that's just the facts of life. Again, hopefully, as we get more help, I think that might change, but I don't think it's ever going to get to the point where I can see people as frequently as I would like to. I just don't think there's ever going to be enough of us to accommodate for that. But again, technology is good, and I think it is improving. And so you do see a lot of management that way, and I think it's okay. And yes, I don't think it's just Pittsburgh. I see long wait here in Denver too. This is not a Pittsburgh thing. This is a global thing. There's just not enough people to take care of everybody. Am I open to I don't know, Donna. Am I? Um, I like to think I'm open-minded, but you hit me with stuff all the time that I don't know about or have to think about. So am I open to hearing about a new approach to Parkinson's that does not involve dopamine? I'm always open to hearing about things. But I take everything with a grain of salt. Even things that are show up in my journals. Believe me, I don't just take alternative medicine or alternative things or kind of non-fruit, non-dopamine things with a grain of salt. I take dopamine things with a grain of salt too. This is why I don't get excited when I hear about new things that haven't been proven yet. And so the short answer is yes, I'm always open to hearing about just about anything, and I will give proper thought to anything you can think of. It's just I take everything with a grain of salt, and I really am. I need to see the evidence before I do it. It's a great question. So Donna, you can send it to me at a different time. Send it to me in a message. I'll look into it. Which medicines are best for balance and walk? Well, the short answer is physical therapy. None of the medicines are particularly great for balance and walking. Um, I prefer, and this is my opinion, this is not proven. None of them have really been proven to help with walking and balance all that much. I prefer things like amantadine to carbidopa-levodopa. I think amantadine works a little bit better for walking and balance. This is where you'll see me use non-dopamine medicine. So I'll use the anticholinergic medicines like Exelon or Aricept to try to help with walking and balance. But because walking imbalance is such a dangerous problem, you will see me use things that may not make sense. I'll use methylphenidate to see if I can help with freezing of gait, even though the data is very weak. I'll use Topamax for walking imbalance. I'll use Riluzole, which is an ALS medicine for ataxia. And not that any of these medicines really have a ton of evidence or good support for their use, but nothing does. And because walking imbalance is such a difficult and dangerous problem, I always harp on exercise, 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 and physical therapy, physical therapy, physical therapy, because that is the only thing, as far as I know, ever proven to help with walking and balance. But I will try just about everything in that case. Is there a particular book or site that I would recommend specifically for progressive supranuclear palsy? So PSP is one of the Parkinson's plus conditions or Parkinson's-like conditions. And the short answer is I don't know that there's any website specifically for PSP. But I think the Michael J. Fox Foundation website covers just about everything, including the atypicals. Casey, I don't know, do you guys have anything on the atypicals on yours?
I thought there was
I
a
haven't looked
specific,
that close.
yeah, I thought there was a specific organization for PSP.
There is. I mean, there's
Yes,
organizations for everything.
yes.
There's an MSA
Oh, there it is.
coalition, there's a PSP group, but they're
Pure
hard to find.
PSP.
And so I usually refer everything to Michael J. Fox Foundation is
Mhm.
probably the biggest in the country in terms of Parkinson's disease, but they also cover the Parkinsonisms as well. And so that would probably be a good place to
Mhm.
start.
And I knew Karen would have one, purepsp.org.
There you go.
Yes.
See,
Thank you.
there's always something. Is there a
Hmm.
is there a phone app that helps me with patients? Not really. So again, one of the things that is coming is the use of AI, artificial intelligence, and again, much going back to I'm an old person in a younger person body. I don't really like new things. I'm awfully actually open-minded and excited about the use of technology, artificial intelligence, how it's going to help change medicine, taking care of patients, so on and so forth. And one of the things is kind of wearable devices, phone apps, things that can directly connect without us actually having to see each other face to face. Because again, office time and space is so difficult to get that I think you're going to see the use of technology more and more. Phone apps, wearable devices, non face to face encounter time used, more data, all of these things are coming. I mean, and it doesn't matter if I like it or not, they're all coming. And so you're gonna see more and more of that. There's none that I use necessarily now that are all that helpful. People find different things that they find to be useful, but there's none that I necessarily use on a regular basis or suggest. It's coming. We're going to be bombarded with technology. We're going to be bombarded with artificial intelligence and how we use it. And I'm going to use it too. I'm going to adapt to it. But it's definitely going to be a part of how we take care of patients in the future. And so, again, as things come up, as we adopt new technology, you're going to see it more and more. All right, one more question, and I'm a minute early. How do you feel about swimming as part of PD exercise? I love it. In fact, if I remember correctly, I saw a paper or a poster that actually sort of compared the different types of exercise. And believe it or not, the two that worked the best were swimming and dancing. And so at the end of the day, again, get in the pool. It's Olympic time. Everybody should be swimming. It's so much fun to watch. Makes you want to get in the pool and swim laps. No, it doesn't, but maybe. But swimming is great exercise. It's a whole body exercise. And so I love it as an exercise. It's probably one of the best exercises you can do for cardiovascular health and everything else. So yes, I think swimming is a great exercise as part of Parkinson's disease. And with that, I will pass it back to you, Casey. Thank you for the time. And I don't, when's the next one? I don't know the date. You
Yes,
always know the dates.
September 5th. My wonderful friend, Karen, always gives me that date. We'll see you again on September 5th, and that's still before Step Forward on September 28th. What else? There was something else. Oh, Chance, Pittsburgh Valley Theater is looking to expand their classes. They'd like to have some in person again.
Again,
East
great
End,
exercise.
and looking at the South Hills again. So, not just specialists, medical specialists, but damn. Stay
Some more to
tuned
come. Keep
for
sending in the
sure.
questions. Casey is the gatekeeper. Keep sending them to her, and we'll keep doing it.
Yeah, and thank you, Dr. Leichliter. Yay. Take care,
No
everybody. We'll
problem.
see you
Thank
soon.
you. Have a good one, guys.
Bye.